Welcome to the All Things Physical Therapy podcast. This is your host, DPT Steph, your doctor of physical therapy, bringing you all things PT with an interdisciplinary approach so that you can be the best clinician that you want to be. Thank you for tuning in to the All Things Physical Therapy podcast. This is your host, Stephanie, otherwise known as DPT Steph, doctor of physical therapy, currently working in acute care. On today's episode, we are chatting with Nicolet, a PM&R or Physical Medicine and Rehabilitation, Doctor of Osteopathic Medicine or a DO. And to get us started, Nicolet, why don't you tell us a little bit about yourself?
So my name is Nicolet Finger. I am a DO, a doctor of osteopathic medicine, and I am a physical medicine and rehabilitation resident physician at UT Health San Antonio. So I'm really excited to be here on the podcast today. I do a lot of blogging about my life inside and outside of medicine, and I hope that I can share a little bit of my experience in my life with all of you.
I love it. Thanks for being on. And that's exactly how we connected, was through social media. And I know PM&R and PT, or just being in the rehab world, there's a lot of connections. So I thought this was perfect to have as a discussion for the podcast. Why don't you tell us a little bit about how you got started kind of in your whole role? Did you always know you were PreMed, or did you do a DO versus MD battle, or how did you kind of get to where you are today?
Yeah, so I always thought I wanted to be a doctor, but I can't say I knew what that meant. So, at 13 years old, saying that you want to be a doctor doesn't really mean anything other than you kind of think it's a cool profession. But I had that in my mind in high school and in undergrad. And in undergrad, had a lot of research and public health experience and really loved those, but realized that what was missing out of both of those was the patient interaction. Loved research, loved science, absolutely loved public health, but I just missed, that, or I guess I had never experienced it before, but I wanted that experience of sitting in front of a patient and helping that one person. So that kind of drove me to apply to medical school. And when I applied to medical school, that's when I discovered that, hey, there's this other pathway called the doctor of osteopathic medicine, in addition to it, a doctor of allopathic medicine, which is MD. And so I thought I would just take a look into it. The more I read about the DO degree, the more it aligned with kind of who I am as a person. My undergraduate degree is in nutrition. And so I really felt a connection with the osteopathic profession when I was reading about it applying to medical school. And also, reading about osteopathic manipulative medicine, also abbreviated as OMM, where we use our hands to treat musculoskeletal illnesses and disorders. I felt like that was really cool. I wanted to learn more about that because it seemed at the time, not knowing much about it, like a pretty cool way to take away pain without medication. And so I figured I would keep an open mind as going through interview season through medical school. At the end of my interview season, I sat down with my dad. He's one of those people that you can pretty much just ramble on to, and he won't really give you any actual advice. He'll just let you talk yourself into what you probably would have been doing anyways. But he lets you just vent. And at the end of my conversation with him, I ended up saying, if I don't go the pathway, if I don't, go to medical school in the pathway that I want to, right, and practice medicine in the way that I feel aligns best with who I am, then why am I even going, right? Am I going for other people, or am I going to go to medical school for myself? And when I said that out loud, even though those thoughts had already been going through my head, when I said that out loud, I realized that I really wanted to be a DO. And all of the bias and the negative things I had heard from other people who, in the first place, weren't even in medicine, are what scared me about going DO. And so I decided to throw all that away and to really just go with my heart and my gut. And I have never been happier. And then, of course, deciding to go into PM&R is a whole nother story because I thought I wanted to be an OB-GYN going into medical school. So life really just throws you a bunch of curveballs, and it's really fun to look back and just see kind of how far you came and how your life is so different than you expected it to be. 10, 15 years ago, I wouldn't have never thought I'd be here, but it's so much better at the same time.
That's awesome, and I like that you touched on too, you thought you wanted to be in OBGYN and now you're in PM&R, which obviously are 2 very different spectrums. So
Yes.
I do wanna hear the story. So you had this one mindset, now you're going through your years of coursework, and then you're starting to get more clinical, hands-on experience. How did you end up in PM&R?
Yeah, so I thought I wanted to do or I thought I wanted to do OB-GYN because I liked women's health. Part of like the public health that I spoke about that I did in undergrad was helping women with overcome eating disorders. And I loved that. I felt like I was really good at making connections with other women and making them feel comfortable in uncomfortable situations. And so I thought, well, maybe OB-GYN is the right thing for me. And I loved studying repro. And so it just, even through first and second year of medical school, it all started to fit together and everything pointed towards OB-GYN. And then I did my clerkships, my rotations, and about the first week of my OB-GYN rotation, I just thought to myself, I don't know if I can do this every day. And that is nothing about the specialty. That's nothing about, the people who go into it. It's an amazing specialty, and the people who go into OB-GYN, you know, deserve so much credit. But I couldn't see myself doing it every day. I came home and I wasn't happy. I didn't want to talk about my rotation. I honestly just wanted to get away from it when I came home. And I think that's something that I would tell people to pay attention to, right? When you do that. And some people may feel the same way when they go on to PM&R, right? They may go home from a PM&R rotation and say, oh, I hated it and I just want to get away from it. But you have to pay attention to how you feel after your rotations. And so I kind of had a crisis, right? I was thinking, oh my goodness, the last 2 years, I thought I wanted to do this one thing and I don't. So now should I have even come to medical school? Like what do I want to do at this point? So I reached out. Actually, my boyfriend at the time, now my fiance, his roommate was going into PM&R. And of course, I'm sitting on their couch one night venting about how I have no idea what I want to do in life anymore. And his roommate said, you would be a good fit for PM&R. Why don't you just go talk to my mentor, just set up a meeting and just pick his brain? And I was so desperate. I said, okay, sure. Give me his email. I sent him an email. His name's Dr. Omar Salad, still my mentor to this day. I sat down with him, just picked his brain about what PM&R was, what it was all about. And he looked at me and he said, do 1 month of a rotation with me and you will go PM&R. I can tell. He was like, I can know your personality type. I know that you will fall in love with PM&R. And I said, challenge accepted. So I did a rotation with him, a 1 month long rotation. And I fell in love with the fact that we give patients hope. I think in medicine, we get bogged down a lot with patients who are so sick and the recovery is so long. And in PM&R, you see a different side of that. You see people who have hope. You see people who didn't have hope, who, let's say, had cancer, they've recovered from cancer, but now they're still stuck with a poor quality of life because they're dependent on people to help them walk or brush their teeth or use the bathroom. And then they come to see you as a PM&R physician. They work with the PTs, the OTs, the speech therapists, everyone who works on our team together. And then they have hope, they say, wow, I maybe one day I can walk on my own, or maybe if I can't walk on my own, but I can use the bathroom on my own. I can have that sort of privacy to myself. Those things are so empowering to patients. And to see that side of medicine totally changed my view. I feel really lucky to have had that experience when I, was having that sort of crisis of should I have even come to medical school. I feel lucky to have found a mentor who showed me that side of medicine because it totally changed my life. And I was all in as soon as the first, I think it was maybe the second week into my rotation, I told Dr. Salad, I'm in. What do I need to do? Get me on research studies, get me in the volunteer, like help me volunteer. I will do everything I can to go PM&R. And so that's kind of how it all came together, but
That's awesome. So we keep saying PM&R, and for
Mhm.
those who maybe are listening and they're like, why do they keep saying these three letters? Like, what in God's name does this mean? To someone who has no idea what it is, give us a short summary of, I guess, like what defines PM&R.
Yeah. So PM and R, a lot of people think we put like an N there. So it's PM and R, and it stands for Physical Medicine and Rehabilitation. So you can kind of take those words just as they are, right? Physical medicine, we deal with musculoskeletal disorders and illnesses, and rehabilitation. So we deal with the rehabilitation of those disorders. But there's a lot of overlap with other things other than just musculoskeletal disorders. Some really common examples that we see in our patients are brain injuries. So, brain injury patients, they need a lot of rehabilitation because because of the neurologic impact of the brain injury, they end up losing their ability to walk, to speak, to eat, to function on their own, to use the bathroom on their own, all of those little tasks. Same thing happens with spinal cord injuries, another big patient population that we deal with. um, let's say they get in a car accident, right, and they break their neck or their back and they can't walk, maybe they can't use their hands, they can't eat, they can't talk. um, all of those things kind of go hand in hand with PM&R. And then from there you get into pretty much anything, any disorder or any illness or accident that causes an acute problem that somebody then later needs to go to rehab to recover from, can be treated with PM&R. And the example that I give for kind of the bread and butter PM&R is inpatient rehab. And so this is probably the most perfect definition of PM&R, though it does stem outside of that. But in inpatient rehab, you have the physiatrist. A physiatrist is another name for a PM&R physician. So you have the physiatrist as team lead. And then working with the physiatrist, you have physical therapists, you have occupational therapists, speech therapists, respiratory therapists, recreational therapists. I mean, the list goes on. You're working with PAs, with NPs, with nurses, people of every different specialty and discipline. And every single person on that team works to the betterment of one patient. So it's a very, very collaborative field and very multidisciplinary, which is another thing that draws a lot of people. That's why a lot of people like PM&R. So of course that's the bread and butter definition, but of course if you go to an outpatient clinic, you'll see PM&R physicians who specialize in pain management, who specialize in sports medicine, occupational health, all sorts of things like that. So you can get more specialized within PM&R. But I'd say the inpatient rehab is a good example of how they work with a multidisciplinary team.
Yeah, and I think that's a great example too, because I mean, being a PT in acute care, that's been my major understanding with it.
Hmm.
So I know we'll work with the patients as an acute level, and then we're like, okay, we want a physiatry consult, rehab consult, and then our PM&R docs come in and they're like, okay, this person looks good for inpatient rehab, like we'll take them. We have one in house, so it actually works great because we can collaborate even further. But
Awesome.
this might sound like a really stupid question, and I feel like my judgment still lacks in this field, even though you just defined it for me. So as a PT or the OTs or speech therapists I work with, we're actually like hands-on doing the lifts, the transfers, the ambulation, etc. But the PM&R docs essentially look at our notes, and I guess they have more of like the medical approach to it. Is that like a good way to understand it? So they have like the overarching look
Yeah.
or view of everything, and then based off of more of the medical side, they can clear them for inpatient rehab in addition to what we're doing in PT, OT, etc. Is that a good way of putting
Exactly.
it?
Yeah, yeah, so exactly. And I think we get that question all the time, and it's not a stupid question because it is very confusing, right? I would say that the PTs, OTs, speech therapists, all of the therapists do the majority of the hands-on work, right? As PM&R physicians, a better and an easier way, I guess, to think about it
Medical management, I guess, is like the
is that
better,
we
yeah,
do exactly, is that since we are physicians, we do the medical management
right.
first with the rehab in mind. And so let's say we have a spinal cord injury patient who also has diabetes, heart failure, and hyperlipidemia with peripheral vascular disease,
Mhm.
right? You've got all these
What a
medical
combo.
problems. Yeah, that's like the Texas, we call that like the Texas special or something. But like you have a patient with all these medical problems already, right? And now they have a spinal cord injury. So they need physical therapy, they need occupational therapy, speech therapy. They need all this stuff, but also we have to be really careful with them, right? Because they're going to be they somebody with heart failure who gets a spinal cord injury, their heart failure is going to be exacerbated, right? Their heart failure will no longer be under control because the body's entire physiology changes when somebody has a spinal cord injury. They'll need titration of their medications. Um, Additionally, let's say they've got peripheral vascular disease. Well, now we're dealing with a spinal cord injury patient who's most likely not getting good perfusion to their legs, right? And we have to figure out the medical management, the medical side of that. But we rely heavily on PTs, OTs, speech therapists to tell us what's going on, with the hands-on treatments and therapies. And so truly it is multidisciplinary. We could not do it without you guys. And I would even say that y'all are probably the most important part of the team. Y'all are the most important part. We're there to do the medical management stuff, but you guys do the hands-on work. And I would definitely stress that the team could not be a rehab team without all of you.
Yeah, totally, totally feel that. Totally collaborative. And I know, and I'm sure you've been impacted as well. So this is kind of where I want to take the conversation now, but in COVID times, more so than ever, I'm sure you're seeing your fair share of it. I know New York was hit pretty hard, or the hardest, I'd say, even in March and April. And one of the biggest things that I had to constantly advocate for my patients, they're 85 plus days after the ICU and they're so debilitated. Now we're worrying about like post COVID syndrome. And I'm like, no, I promise they can do 3 hours of inpatient rehab. Like they're trying so hard. And then now there's a whole bunch of medical sides to it too, with everything that's going on top of comorbidities that they may already have. So, how has COVID changed your practice, or has it changed your practice? And what have you kind of been seeing over the past 8 plus months?
Yeah. So, as a resident, I change services every month, right? But I have been able to kind of see what goes on the rehab floors, even if I'm not there, and kind of what that's been entailing. Number one, our beds are being taken by acute beds, which of course we are more than happy to give those up for COVID patients if they need the space. Our number one goal is patients, patient safety, patient health. And so we're more than happy to do that. But that does take away rehab beds, right? We need more space, and therefore we'll give away some of our rehab beds to active COVID patients and make those beds into acute medical, hospitalist beds or intensive beds. The other thing that we're seeing is a lot of this work on COVID rehabilitation. One of actually my department chair, Dr. Monica Verdisco Gutierrez, she is creating a COVID rehabilitation protocol and a COVID rehabilitation unit. And because a lot of these COVID patients, they have number one problems with their lungs, right? But also heart problems, problems with being hypercoagulable, problems, I mean, with all sorts of issues, right? Being in bed that long in say, an ICU setting, being intubated, they'll have myopathy just from critical illness, right? Their muscles are just wasted. And so they need a whole new protocol to overcome this illness. And so I've kind of seen both sides of that. One where, there's the fear that our training will be taken away because we need those beds to be acute beds, intensive beds, but also the really inspiring part of it where we see rehabilitation physicians and therapists coming together to create protocols for these patients once they've recovered, from the initial infection, which is pretty cool. So I think there's still a lot to come. There's still a lot to learn about COVID and COVID's effect on the body and how we're going to help patients recover from it. But overall, I think, you know, I've been fortunate that my residency training has not yet been heavily impacted.
That's good. Yeah. And we had the same situation because I touched on earlier, our inpatient rehab is in-house as well. And it became a COVID unit during our peak.
Hmm.
So we were starting to do almost an inpatient rehab in-house, like on the acute level, because we were seeing patients as much as we could, sometimes even
Hmm.
twice a day, every day, just because they're so debilitated.
Hmm.
Um, Touching back on the collaboration, which I know we said a little bit about earlier, how do you think we can be better from like a PTOT standpoint, and then obviously a resident, or even when you're a, I don't want to say official doctor because you are an official doctor, but like no longer a resident, I guess I can
Yeah.
say. How can we do better as like an interdisciplinary team, or what are some of the things that you think work best to have a true, like a really good collaborative approach?
Yeah. So one of the best approaches I have ever seen was on a rotation at UT Southwestern, actually. And we all, every single morning, would meet in a conference room. And of course, this gets difficult with COVID, right? Because we're all trying to be spaced out. But you could probably do this on Zoom or something similar. But we would all, this was pre COVID, we would all meet in a conference room and we would go down our patient list one by one. And there was no rush. Nobody was trying, this time was actually blocked off for this conversation about every single patient. And we would go one by one, sometimes spending up to 20 minutes talking about one patient because every single person on the treatment team had a chance to speak and was listened to. And so you know, it would start off with the nurses. It would then go to rec therapy, PT, OT, speech therapy. Every single person who has ever seen that patient would talk and let the whole team know the progress, how much progress we have made, and kind of what their thoughts are, what the patient maybe needed to do better on, what our goals could be. And we would all make suggestions in that room. And I think a lot of the times in just general medicine, internal medicine, family medicine, you name it, any specialty, that collaboration is lost because, there's been many times on the internal medicine wards that if I am working in the ICU or I'm just working as a general hospitalist in residency, where I see that communication lost. The nurse doesn't know what our plan is as the doctor. The doctor doesn't know what the nurse is doing. And that's really important, right? For us all to be on the same team. And so I always felt like that meeting is critical for everybody to have the time to speak and be heard. And so that everyone leaves the room that morning saying, here's our plan for the day, here's what we're doing today, right? And if there's any changes, it'll be brought up the next morning as well. So everyone's always on the same page. And kind of similarly, I think another practice I've seen, which is just incredible, is family rounds, where members of the family, this is also something that's affected by COVID
Hmm.
because we can't have family members coming in all day. But pre COVID, we would have the whole family come in and meet us at a certain time. We'd tell the family, okay, 8 a.m. is your family's rounds. And they would meet us in the patient room, and the entire team plus the entire family would be in the patient's room. And we would go one by one, you know, hi, I'm Nicolet. I'm the PM&R physician. We've been working on this and this. This is my goal for you. And then the next person, hi, I'm your PT. We've been working on this and this is our goal for you. And the family got to hear it and the patient got to hear it all. And they felt very included in their own care. So I think both of those practices are very important. And even if we can do those virtually, FaceTiming the family or something with COVID, I think they're extremely important to have those conversations and those meetings.
Yeah, I think that stresses just the overall importance of communication in general, like between not only the team, but also with the patient. Because then you think of now in COVID times where family, I mean, I know every hospital is different. We just started allowing one visitor at a time, but it's only within a certain amount of hours. So if you're doing I know from like a rehab standpoint, if I'm doing a session in the morning and family is not there, I need to really explicitly have this patient understand what it is we're doing, what our goals are, what's kind of going on. And it's going to cost you like a couple of minutes extra here and there, but it's something that we should be prioritizing because it's more important now, more so than ever before.
Hmm. Yeah. And I think people underestimate the importance of family in patient care. There are so many times where I would have missed something if I didn't talk to the family and the family bring up their concern to me, right? Because we don't know the patient every day of their life. We may not notice something that's different from their baseline because we only know them when they've been sick, right? We didn't know them before they were sick. And so to have family giving you that information is invaluable. And I think, that's why I always made sure, even on my ICU rotations, every single day you call the family, right? If they can't come in, every single day you call the family and you update them, answer their questions, let them talk to the patient, right? They are an important part of the treatment team.
Yeah, I think that's just another great point.
Yeah.
um, Caregiver involvement, I think in general is such a huge thing.
Hmm.
And I know I'm more on surgical floors these days, but when I was on like the internal general medicine floors, and you are getting elderly, more so elderly patients who have like no clue what's going on. And you're like, oh my gosh, I only know you when you're delirious or
Hmm.
really sick and you have no clue what's going on and I have no idea how to best help you because I don't even know what you can do or what your baseline is, exactly like you said. So it's
Hmm.
more important than ever. And this is like where the team communication comes in. Well, you'll have to talk to the attending doctor, the residents, as well as the nurses, because they see so much. They're with the patient more than I feel like everybody else is. And then don't be afraid to call social work or case management or whoever
Hmm.
to kind of put all those clues of the puzzle together.
Exactly. Yeah, and I always tell people too, like, I always tell nurses and everything when the first time I work with any therapist, any nurse, any PA, like, don't feel bad about bothering me, right? I'm working right now. I'm on shift. Like, you are welcome to bother me at any time. And actually, it's not even bothering me, right? I always, on rounds, introduce myself to the nurse if I haven't met them before, give them my pager number, give them the way to contact me that day, right? Because that's just communication is absolutely number one. And I think that's why I feel really lucky to be in a field like PM&R because communication is stressed so much in PM&R. And I find that it's not as stressed in other specialties.
Yeah, and I like that you said you introduce yourself, you haven't met them before, you give them all the ways to
Mhm.
contact you. I wish all of you could be that great. No shade to anybody there, but just in general, I think that's a great perk, so hold on to that forever. I know I said when we first started talking, we connected through social media, and obviously you're doing a lot of great work there. So kind of give us an overview of why you created this platform, what your goal is, where you kind of see it going.
Yeah. So when I first started my blog, actually, it was like not even named Nicolet.life. It was a different name, and I just posted about food. I was a nutrition major, so I was just like posting recipes and things like that. And then I got accepted to medical school, and I really had enjoyed communicating with other people on social media and bouncing ideas off people, just networking that way. And so I decided to change the name to Nicolet.life so that I could post about whatever I wanted, right? I didn't want it to be a medical name or another. I wanted it to just be, I could talk about whatever I wanted to talk about. And so I started that and with really no goal in mind at that time. It was just kind of, well, I want to post about whatever I want to post about and I want to connect with other people who have the same interests as me. But over time, I realized how impactful social media can be when mentoring or when wanting to be mentored, right, by someone above you. Um, and also just to connect like with you, right? You are not in the medical PM&R, like, med school, but you are in my field. And that's so cool, right? That we were able to connect this way. And I don't know, we probably wouldn't have connected if it wasn't for that. There's no other way we really would have,
Yeah.
right? And so I just fell in love with that part of it, that part of social media. Then when it came time to apply to residency, I had this, realization that I kind of had to decide if I wanted to make my social media private or public because most likely residency programs that I was applying to would find me on social media, just because they usually look people up to make sure that you're a normal person and whatever. And I decided to keep mine public. I combed through my own social media and I thought, you know what? This is truly a representation of who I am. And yeah, I've got some personal stuff on here. Like I posted about my engagement. I posted about, right? I post personal stuff, but at the same time, nothing, I'm not hiding any of that a part of me, right? And I thought to myself, well, so what if I posted a yoga flow, right? And I'm applying to residency? Well, they'll just know that I was serious when I put that on my hobby section, right? They'll know that that's really true. Like I really do practice yoga. I really do go hiking, like all of those things. And so I decided I'm going to keep it public. And if people don't like it, then that's okay, right? Then maybe that's not a program I want to be at if they're not okay with that. And I found it to be so helpful, right? People really feel like they know you more when they have seen your social media profile. And I, for that reason, encourage people, especially now with COVID, with interviews all being virtual, to make a social media. You don't have to have 1,000 followers. You don't have to, post all the time. You don't have to even post educational content. But I encourage people to put their real name, in the bio, put something like whatever, where they went to school, where they go to medical school, maybe, aspiring physiatrist or aspiring physical therapist, and put a professional photo. And just every once in a while, you can post things like where you volunteered or a cool experience you had in school or something like that. Because when you're interviewing, if people can find that, right, that only adds to your application. Then they can see you in a totally different light and you have full control over what you put on the internet. So you just make that decision about what you want people to see about you and what you don't. And if it is a good reflection of who you are, then it will only work in your favor. So I usually encourage people, especially now, to make to make a social media profile. Take control over your digital footprint because likely there's already pictures or whatever. If someone Googles your name, likely they're going to find something anyways. You might as well have control over what's being posted, right?
Yeah.
So I think it's important. I think it is definitely kind of a new age thing that we have, especially now that literally everything is virtual. But yeah.
I feel like it's also grown. I mean, I graduated PT school a year. Wait, I don't even know what year it is anymore. Over a year ago at this point. That took me a second. Like almost 2 years ago. Wow. Okay, reality check. Um, but I mean, I even feel like just as I was a student going through this past several years, like there was not a lot on social media. And I don't know what this huge uptick is, or it's even more prevalent now because of COVID. But I think it's great because I'm now, so this is a perfect example. I'm now learning more what PM&R is without asking the weird attending that I sometimes talk to and making awkward conversation and like being like, excuse me, sir, what are you doing with my patient? So like this is great. And I think just using the platform where we're bringing awareness to our professions, but then also just continuing to connect to ultimately be better for our patients.
I
And
agree.
I
Yeah.
agree. It's like such a good little takeaway to all of
Hmm.
this. What are any final thoughts or tips you have for students that maybe want to go into PT or want to go into PM&R or just like medicine or healthcare in general?
Yeah. So I think number one would be to explore all your options because I'm definitely one of those people who, when I grew up thinking, oh, I want to be a doctor. I mean, when you're young, kind of, I think that's like the only profession in medicine that's like highly promoted, right? But what you don't realize when you're young thinking, oh, I want to be a doctor, is there are so many medical professionals and they're also such important part of the team and they all do different things, right? So you really should look at all your options and decide what profession is best for you because you can be in the medical field in like 15 to 20 different, I mean there are so many jobs in the medical field all doing different things, all contributing to patient healthcare. And so like I know the classic, med school interview thing is like, why do you want to be a doctor? And it's because I want to help people. But you help people in so many
Yep.
ways and so many different aspects in medicine, all the different, career paths that you can choose in medicine. And so that would be my number one tip is truly explore all of those options. Another plug for social media because you can do that on social media.
Mm-hmm.
You can find all of these people and ask them what they do and ask them why they like their job, and why they chose it. And then the next is to not follow, anyone else's path. You're unique, and medicine needs you because of what you will bring to medicine, not because you're a clone of somebody else or because you're following in the footsteps of somebody else. If it takes you 2 extra years to do something, so be it. If you decide to take a gap year and go be a teacher and then go to medicine, or, so be it. You make your own career path, and every single experience that you have along the way will make you a better provider in the future. And so I would encourage people, not to compare themselves.
I love those because those are just takeaways that can be applied to a variety of healthcare things, and I totally, totally agree with all of it. If people want to contact you, where can they find you and reach out if they have any questions?
So my Instagram is where I'm most active, and it's nicolet.life, Nicolet.life. And then from there, you can see all of my blogs and other links that I have there in my bio. But that's probably the main way to contact me.
Perfect. I love it. There you guys have it. That was Nicolet, our lovely PM&R resident. And thank you so much for coming on today. And it was great to chat with you.
Thanks for having me.
Thank you for listening to this episode of the All Things Physical Therapy podcast. Make sure to leave a review and subscribe to stay updated on new episodes. You can find more episodes like these on Apple Podcasts and Spotify. And to stay up to date, follow dpt.stuff on Instagram or go to www.dptstuff.com.